Good morning to all of you. Uh, today, uh, today I just taking the lecture on neonatal jaundice and phototherapy. Myself, Dr. Brajendra Singh, uh, completed my graduation and PG from JNMCH Aligarh Muslim University and followed by DNB and fellowship in neonatology from Jolly Grant. Currently working in Singh Government Medical College, Bulandshahr, UP as assistant professor. So thank you so much to all respected senior and teacher and NNF office bearer for providing this opportunity to share my thoughts about this topic. This is my profile. So today's session objective are neonatal jaundice pathophysiology and some details about the phototherapy and some little bit about bilirubin toxicity and action transfusion. So in introduction, neonatal jaundice is described as yellowish discoloration of the skin, mucous membrane, and sclera. Yellowish discoloration first evident on the skin of the face, nasolabial uh, folds, and tip of the nose. Jaundice is observed during the first week after birth in approximately 60% of the term newborn and 80% of preterm infant. Means in every newborn care unit, this is most prevalent problem. So our objective is to deal with it as early as possible at periphery to decrease the load at higher center and decrease the morbidity related with this. This is typical picture of neonatal jaundice. So by definition, neonatal jaundice or hyperbilirubinemia, total bilirubin more than 95th percentile on the our specific Bhutani nomogram. As severe hyperbilirubinemia, if onset before 24 hours of the age, elevation of total serum bilirubin that required phototherapy, or rise in total serum bilirubin level more than 0.2 milligram per dl per hour. Associated sign of the illness is like vomiting, lethargy, poor feeding, excessive weight loss, apnea, tachypnea, temperature instability, and jaundice persisting after 40 days in the terminal infant. So for the severe hyperbilirubinemia, we can look for these five characteristics. This is the bilirubin metabolism, and this is physiological jaundice. Mostly in newborn, this is common phenomena of neonatal jaundice, and in which mostly is physiological jaundice. So for the term baby, this appear between 36 to 72 hours of life and peak at 4 days and disappear by 10 days. And serum bilirubin does not exceed 15 milligram DL. And in preterm babies, onset similar to the term baby, peak by 5 to 6 days, and serum bilirubin may go up to the 15 milligram per DL and may persist till 14 days. This can be better understand by this graph. This is the graph showing bilirubin level and age in the at x-axis. First line above showing cutoff 15 milligram per DL, and the second one is preterm. This is showing onset of the jaundice and peak at 5 to 6 days, and it may persist till 13-14 days, and this is about to touching 15 milligram per DL cutoff. And in case of term, this is onset is similar but peak earlier like 3 to 4 days, and this is become normal at 10th day, and this is um, peak, this its peak below the preterm peak and never touching the 15th. And in case of etiology of physiological jaundice, these are the common etiology. We will not discuss in detail because this class is totally practical purpose and skill purpose. So these are the common cause. I will share all the theory part to you to read and learn, but we will discuss here more and more practical point. This is pathological jaundice cause. Pathological jaundice occurrence within 24 hours of life in always pathological, and jaundice is in newborn does not fall in the time frame of the physiological jaundice. It is designated as pathological jaundice. So simple thing is pathological jaundice when in first 24 hours or not following the time frame of physiological jaundice. The common cause of those pathological jaundice are immaturity, hemorrhagic disease of newborn or fetal-maternal blood group incompatibility, breast milk jaundice, hypothyroidism, pyloric stenosis. These are the lower one is rare causes. So this table showing causes as per postnatal age. So first table showing within 24 hour causes of jaundice after within 24-hour birth. If within 24-hour birth, then always pathological jaundice. And these causes are mentioned like hemolytic disease, intrauterine infection, deficiency of red cell enzyme, some drugs are there, and hereditary spherocytosis. And second one showing between 24 to 72 hours of the age. This also showing this is also time frame for the physiological jaundice, and causes are like immaturity, birth asphyxia, acidosis, hypothermia, and so on. Third, after 72 hours of the age and within first 2 weeks, like septicemia, neonatal hepatitis, breast milk jaundice, acetylphthalate atresia, and metabolic diseases. Now, important thing is ABU, isoimmunization, and ABU mismatch found in about 15% pregnancy, and one third have Coombs positive, and 15% of the Coombs positive have significant jaundice. About 1% pregnancy occurs in the 1% pregnancy and recurrence 90%. Peak rises at day one, then slow rise follows. So 50% hazardous jaundice due to ABO mismatch. It means ABO mismatch is very dangerous. So we strictly asked for the ABO mismatch because this can lead to maximum morbidity due to neonatal jaundice. So now, since today, just focus on this slide. This is thumb rule. Thumb rule. This is made by just me to learn and memorize that mother is never negative. Mother is never negative or emotionless for her baby. Means माँ कभी भी अपने बच्चे के लिए नेगेटिव नहीं सोचती है. नेगेटिव मतलब RH नेगेटिव नहीं होना चाहिए. मदर नेवर इमोशनलेस फॉर हर बेबी. मदर कभी भी अपने बच्चे के लिए इमोशनलेस नहीं होती है. मीन्स हमेशा उसके इमोशंस बच्चे के लिए होते हैं. मीन्स मदर के इमोशंस बच्चे के लिए जीरो नहीं होते हैं. तो इसका मीनिंग क्या हुआ? अगर मदर नेगेटिव है, इफ मदर इज RH नेगेटिव blood group, then baby blood group is very important to rule out RH isoimmunization. And if mother is emotionless or mother with O blood group, emotionless means zero means O blood group. If mother is O blood group, then baby blood group also important. Maybe chances of ABO mismatch. So both mismatch can lead to hemolysis, which increase the chances of NNH and leading to the morbidity of the NNH. This is another example of breastfeeding jaundice. Typically occurs in the lactation failure during the first postnatal week and insufficient intake with weight loss. And this is due to decrease uh, decrease intake of milk and slow bilirubin elimination and decrease intrahepatic circulation. And typically begins after 3 to 5 postnatal days and peak by 10 to 14 days. And if breastfeeding is continued, gradually return to the normal over 3 to 12 weeks. There is excessive weight loss due to inadequate feeding, and colonization of gut is delayed in breastfeed infant. So deconjugation of bilirubin and increase intrahepatic circulation and lead to more TSB rise. Second thing is breast milk jaundice. This is due to hepatic conjugation is compromised due to 3 alpha 20 beta pregnenolone diol in women. So this inhibitory substance in breast milk is excreted for 2 to 4 weeks, and breastfeed should be continued unless critical level of bilirubin reached. Babies with breastfeed milk jaundice pass colorless urine and yellow stool. Cessation of breastfeeding for about 48 to 72 hours, which can lead to fall in 2 to 6 milligram per dl in serum bilirubin, and breastfeeding can be re-established with any recurrence of jaundice. Currently, no justification to stop breastfeeding, so we can continue also breastfeeding. Aggressive and frequent breastfeeding without any supplementation is associated with the faster resolution of the breastfeeding milk jaundice. So, important thing is breastfeeding jaundice due to less milk intake. ब्रेस्ट मिल्क जॉइंटिस फीड मतलब बेबी को मिल्क कम मिल रहा है. ब्रेस्ट मिल्क जॉइंटिस मिल्क में कुछ ऐसा है जो हमें बेबी के कॉन्जुगेशन को कम कर रहा है. सो डिफरेंस इज वेरी क्लियर, एंड इन बोथ केस currently suggested we can increase breast intake, breast milk intake, both can be resolved. Now, approach for the neonatal jaundice. This is theory part till here. Now, important thing is we can learn the things more seriously from here. Like approach for neonatal jaundice tool is, first tool is clinical history. Second is examination, Kramer index, Kramer Jones. Third is transcutaneous bilirubimeter, total serum bilirubin and other tests. And level can be check the severity by different charts, and according to that cutoff we can start treatment like phototherapy and etc. After treatment we can plan discharge and follow up. So these are the tools to manage the neonatal jaundice baby. So we can follow this cycle properly at early periphery center to manage the baby uh, at periphery without any morbidity. So in clinical history, we just ask these important factors like gestational age, mother blood group, postnatal age, birth weight and current weight, hypothyroidism, presence of neurotoxicity factor, and sign of biliary encephalopathy. So gestational age समझ में आता है, मदर ब्लड ग्रुप समझ में आता है ना, पोस्टनेटल एज ये भी समझ में आता है, बट बर्थ वेट एंड करंट वेट का मीनिंग ये है कि हम पता कर पाए कि बेबी का फीडिंग कैसे चल रहा है. कहीं बेबी न्यूट्रिशन डिफिशियंसी में, कहीं बेबी ऐसा तो नहीं है कि डिहाइड्रेशन में है. सो बर्थ वेट एंड करंट वेट ऑल्सो वेरी इंपॉर्टेंट, एंड presence of neurotoxicity risk factor. These are the some neurotoxicity risk factor like asphyxia, lethargy, temperature instability, sepsis, acidosis, and albumin level is less. So we can take some history part and some clinical examination like sign of bilirubin nephropathy and some lab parameter as a neurotoxicity risk factor. So in examination, we can go for the Kramer zone. We just press the uh, skin like we look for the capillary refill time and just check the uh, yellowness of the that area and correlate with this table where at with John how much yellowness present and corresponding area showing the cutoff level approximate TS total serum bilirubin level. So we just uh, in triage area we just receive the baby, we just take the history and just clinically examine the uh, grammar area. So this table, if baby is uh, showing yellowness after pinching the skin at till leg and arm and forearm, it means if mild jaundice, then lemon yellow showing 11 to 13, and if deep jaundice showing 14 to 16, fourth zone, and if fifth zone, palm and soil east means lemon yellow showing cutoff 13 to 15, and deep jaundice means orange color showing more than 17. Second tool is uh, like transcutaneous bilirubin. We if at periphery NBSU SNCU we having transcutaneous bilirubin, then okay, good. If not available, then we can just screen or initial assessment done by Kramer index. So if available, then just assess in natural light, daylight by observing cephalocaudal progression and transfusion millimeter work on the principle of computerized spectrometry. This is another bilorimeter showing correlation TSB generally less than 3 milligram DL of TCB if TCB less than 15 milligram per DL means हम जो TCB चेक करते हैं उसमें डिफरेंस जो होता है वो मैक्सिमम 3 का डिफरेंस होता है अगर बच्चे का सीरम बिलिरुबिन 15 से नीचे है, 15 से ज़्यादा है तो फिर वो डिफरेंस वेरी कर सकता है. And both the device Philips and Draeger showing different reading like underestimate करता है Philips का 1 and 2 milligram above 15 DL and Draeger है overestimate करता है 1 and 2 का above 15 DL. So chances of accuracy more with TCB in correlation with total serum bilirubin is less than 15 milligram DL. These are another instrument. So total after history, second examination Kramer index, and total serum, total transcutaneous bilirubin. Then now we can go for the total serum bilirubin. TSP, DCT, MBG, BBG, CBC, thyroid profile, CRP, and GBP with retic count and toxic granules. These investigation is important according to this approach. Like हम just TCB पता करेंगे, DCT पता करेंगे, hemolytic प्रॉब्लम है या नहीं है, उसके बाद में hemolytic प्रॉब्लम है, ब्लड ग्रुप पता करेंगे और CBC पता करेंगे, हेमाटोक्रिट देखेंगे. सेप्सिस को रूल आउट करने के लिए CRP और GBP में टॉक्सिक ग्रेन्यूल्स देखेंगे. Now next, now we are at a stage where we have total serum bilirubin level. Now we just uh, go at the check the severity level of the uh, neonatal jaundice, so we can decide final definitive treatment like phototherapy, continuation or need of extended transfusion or other treatment. So we go for the chart. These are the recent update for the chart as per American Academy of Pediatrics. Those are 2022 charts. These charts are for more than 35 weeks. Gestational and characteristic of these chart are gestational age-based stratification, not for less than 35 week baby, separate based on the neurotoxicity risk factor, and different chart for the phototherapy and exchange cutoff. So total 4 chart are as below I describe. Phototherapy cutoff for no neurotoxicity for one and more neurotoxicity risk factor, exchange cutoff for no neurotoxicity factor, and exchange cutoff for one and more neurotoxicity factor. And these chart having higher threshold compared to previous chart and higher accuracy in first 72 hours. So these are the just flow diagram for the analysis of chart. First I presented history, for then clinical examination, Kramer zone, transcutaneous bilirubin and TC, total serum bilirubin. So हमने TC basically I am just using Hindi also because more people connected with us in this platform can understand in Hindi along with English too. So I just repeat in Hindi also at some important points are there. So this table is very important for everybody, that here we just reach total serum bilirubin level. Now just we check the gestational age. If gestational is more than 35 weeks, then we go for the phototherapy cutoff and we look for the risk factor. If risk factor present, then chart number 1 used for phototherapy and without risk factor, and chart number 2 used for the phototherapy cutoff with one and more risk factor, and chart number 3 for exchange cutoff without risk factor, and chart number 4 for exchange cutoff with risk factor, one and more. And if gestational is less than 35 weeks, then we check table which is provided by American Academy of Pediatrics for both phototherapy and exchange transfusion cutoff for different gestational age. So this is chart number 1 showing phototherapy threshold, no neurotoxicity risk factor. प्लीज हमको ये चार्ट ही समझने हैं आज, तो यही डिसाइड करेंगे हमें इंटरवेंशन क्या करना है। बच्चे को घर भेजना है, बैक टू होम, और जस्ट ट्रीट एट पेरिफेरी, और just refer to higher center for intervention. So this is chart number 1. Chart number 1 showing phototherapy threshold, no hyperbilirubinemia neurotoxicity risk factor. Now just look clearly. This is showing axis for total serum bilirubin level. This is showing postnatal age in hour of life. बच्चा कितने दिन का हो गया है जन्म लेने के बाद में. दिस इज शोइंग रिस्क फैक्टर का स्टेटस क्या है, रिस्क फैक्टर है या नहीं है. दिस इज जेस्टेशनल एज, कलर कोडिंग फॉर जेस्टेशनल एज. सो दिस इज इंफॉर्मेशन एट दिस ग्राफ. अगर हमें इस ग्राफ की एनालिसिस करनी है तो ये पैरामीटर्स हमारे हिस्ट्री और एग्जामिनेशन में होने चाहिए, हमारे पास होना चाहिए. क्या होना चाहिए, बिलिरुबिन लेवल होना चाहिए, पोस्टनेटल एज होनी चाहिए, रिस्क फैक्टर होना चाहिए, जेस्टेशनल एज पता होना चाहिए. ठीक है. सो दिस इज चार्ट नंबर 1. दिस इज चार्ट नंबर 2. चार्ट नंबर 2 शोइंग phototherapy cutoff for one or more risk factor present for the different gestational age at different hour of life for different value of for one value of total serum bilirubin level. Now, just for a case scenario, this is the case. टोटल सीरम बिलिरुबिन ये हमारे पास एक केस आया है जिसका बिलिरुबिन लेवल 26 है, 60 घंटे में हमारे पास आया है और रिस्क फैक्टर एक प्रेजेंट है, सीवियर बर्थ एस्फिक्सिया है बच्चे को, जेस्टेशनल एज कितना है 36 वीक। अब हमें ये देखना है इसका फोटोथेरेपी कट ऑफ कितना है, हाउ मच फोटोथेरेपी कट ऑफ। सो 60 आवर्स पे आया है, ठीक है। तो जस्ट गो एट x-axis for 60 hours and this graph reaching to the this line because this is baby of 36 week and this line showing for the 36 week level of bilirubin level for 36 week. And so just check how much cutoff. This is showing 14.2. So this baby is eligible for the phototherapy because phototherapy cutoff 14.2. If cutoff more than 14.2 means this baby is eligible because this is this baby total serum bilirubin is 26. So this baby is eligible for the phototherapy. Now chart number 3. Chart number 3 for which exchange transfusion cutoff without neurotoxicity risk factor. This is for chart एक्शन ट्रांसफ्यूजन कट ऑफ। जब रिस्क फैक्टर नहीं है तो चार्ट नंबर 3 यूज करेंगे, किसके लिए, एक्शन ट्रांसफ्यूजन कट ऑफ के लिए। चार्ट नंबर 4 किसके लिए, एक्शन ट्रांसफ्यूजन कट ऑफ फॉर न्यूरोटॉक्सिसिटी रिस्क फैक्टर 1 or more. Okay, now just we analyze our case. Our case क्या था, a total serum bilirubin 26, 60 hours of life and risk factor 1, severe birth asphyxia and gestational age 36 week. Now what is the action transfusion cutoff for this baby? So just look, this is 60 hours of life and line touching the 36 week and cutoff is 20. So this baby action transfusion cutoff with neurotoxicity risk factor is 20 and baby का कितना है 26. So this baby also eligible for the action transfusion. Understand? This is analysis of these graph which is very important. Every periphery center पर ये ग्राफ स्टिक होने चाहिए ट्राइजिस एरिया में और इसकी एनालिसिस हमें करना ऐसे आना चाहिए, ठीक है। एंड नाउ अब क्या हुआ, दिस इज द टेबल एज आई डिस्कस अर्लियर फॉर द बेबी लेस देन 35 वीक प्रेजेंटेड टू अवर ट्राइज एरिया। अगर कोई बच्चा 35 वीक से कम का है तो उसका हमें फोटोथेरेपी कट ऑफ जानने के लिए, एक्शन कट ऑफ जानने के लिए इसको हमें रिफर करना है। अगर बच्चा कोई हमारा 28 वीक से कम का है तो उसका फोटोथेरेपी कट ऑफ 5 to 6 के बीच में आएगा। 23 वीक से कम का बच्चा है, अगर उसका बिलिरुबिन लेवल 5 आ रहा है तो फोटोथेरेपी लगा देंगे। अगर उसका 11 से ज़्यादा आ रहा है तो उसको हम एशियन ट्रांसफ्यूजन के लिए कंसीडर करेंगे। दिस इज टेबल एज पर अमेरिकन अकेडमी ऑफ पीडियाट्रिक्स। ओके, दिस इज सो वी कवर्ड ऑल द बेबी why 4 chart for less than more than 435 week and why one table if baby is less than 35 week. Okay, now look for the parameter we required, corrected gestational age. Okay, if baby is delivered by 28 week but presented to in our emergency by 10 days, then it can fall into corrected age 29 week plus 3 days. So we can go for the second one, so corrected gestation age. This is total serum bilirubin level and here we not consider risk factor and not consider birth weight, just require corrected gestation age and total serum bilirubin level. These are the second guideline, nice guideline for less than 35 week. This here some charts are available. Important difference is this: these charts are for individual gestational age. This chart for only 26 week gestational age, and same chart showing both level, phototherapy cutoff level and exchange level. So this is difference from American Academy of Pediatrics guideline chart and NICE guideline chart. Differences like here single chart for single gestational age showing both cutoff, phototherapy cutoff and exchange cutoff on single chart for different age, different hours of life. So we required gestational age, postnatal age, total serum bilirubin level, and exchange cutoff and phototherapy cutoff we can find. No need of risk factor here. This is another chart for 28 week, and these charts summarized in the form of table by NICE guideline team. This table you can also use in your uh, ट्राइज एरिया, ठीक है. We can use NICE guideline also. So this table showing 23 week baby if coming within 12 hours, then cut off 3.24 for phototherapy. Coming for 24 hour, then 4 cut off. 48 hour, 4.9 cut off. If more than 72 hours, then 7.6 cut off. And same for exchange transfusion, 6.1 at 12 hour, 7.6 at 24 hour, 10.5 at 48 hour, and 13.5 at 72 hour. This means the gestational age for different duration of time after birth, phototherapy cutoff are there, exchange transfusion cutoff are there. So we can also refer this table for less than 35 week. This is very important chart we are using lot. These are old American Academy of Pediatrics chart, but we will not use now because their threshold is low for the intervention. So these are not used now. These are the phototherapy old chart. These are exchange transfusion chart, also not used now because these threshold cutoff is very low. So intervention are more in past. So just updated as I discussed earlier 4 chart. These are Bhutani nomogram chart. This is very important. Now please understand clearly these chart for risk percentage of jaundice in follow up means जब आप बेबी को डिस्चार्ज करेंगे उसके डिस्चार्ज करते समय आप बच्चे का बिलिरुबिन लेवल कराएंगे, ठीक है. और बिलिरुबिन लेवल करा के फिर ये देखेंगे कि बेबी का बिलिरुबिन लेवल किस जोन में जा रहा है, ठीक है. तो क्या जोन है? हाई रिस्क जोन, हाई रिस्क इंटरमीडिएट जोन, लो इंटरमीडिएट जोन एंड लोअर रिस्क जोन. मींस अगर बेबी का आपने डिस्चार्ज आप 60 आवर्स पे कर रहे हैं, उस टाइम पे उसका बिलिरुबिन लेवल अगर 16 आ रहा है, ठीक है, तो ये हाई रिस्क जोन में है. अगर उसका 12 आ रहा है, 13 आ रहा है, तो हाई इंटरमीडिएट रिस्क जोन में है. अगर इसका 11 आ रहा है तो लो इंटरमीडिएट जोन में है. अगर इसका 9 से कम आ रहा है 16 आवर पे तो ये लो रिस्क जोन में है. इसका मीनिंग क्या हुआ? इसका मतलब ये है कि जब हम ये करके भेजेंगे तो हम उसका फॉलो अप की फ्रिक्वेंसी डिसाइड करेंगे. हमने बच्चा डिस्चार्ज कर दिया और बच्चा हाई रिस्क जोन में है तो उसका हम फॉलो अप अर्ली करेंगे. अगर हमने बच्चा डिस्चार्ज किया, उसका एट द डिस्चार्ज टाइम पे बिलिरुबिन लेवल लो रिस्क जोन में है, तो उसमें हमें टेंशन नहीं लेनी है, ठीक है. तो जस्ट लुक दिस रिस्क जोन प्रेडिक्टर. This is showing if baby in high risk zone, then in this study showing 40%, about 40% chances of readmission. And if baby in intermediate risk zone, then 13% chances of readmission. If low in intermediate risk zone, then about 2.2% chances of readmission. And if baby in low risk zone, then about 0% chances of baby readmission for the neonatal jaundice. So is there an easier way for the analysis of this? Yes, some online charts, web apps, and Bilitools like this. This is the screenshot of app in which just fill the details, birth weight, birth time, sampling, and all the things. If you just fill these things and tick the risk factor, city risk factor, like just like this, then you just find the details after submission. You just find the graph. You just find the graph and just uh, got the your serum bilirubin level where exists for therapy range or no intervention range or action transfusion range. So now we go for the prevention and supportive measures. In prevention, just we ensure adequate feeding. If अगर हम जब बच्चे को डिस्चार्ज कर रहे हैं और चाहते हैं कि बच्चे को जॉन्डिस ना हो, तो हम ये बताएंगे कि फीडिंग को इंश्योर करना है। और फीडिंग को इंश्योर करने के लिए पोजीशन, अटैचमेंट, मदर का फीड ज़्यादा हो, एवरीथिंग शुड बी काउंसिल फॉर एडिक्वेट फीडिंग। ठीक है। एंड इन केस ऑफ phenobarb, we can also use to induce enzymatic activity for the conjugation, and this should be used in these different conditions like serum bilirubin, cord bilirubin layer more than 2.5, early onset of neonatal jaundice, cephalometoma, G6PD deficiency, and type 2 Crigler-Najjar syndrome. And these are the other intervention like aspiration of cephalometoma and clofibrate, these drugs. Now we go for the management. First management is phototherapy. Second is action transfusion, and sometimes we just use IVIG, immunoglobulin. So this is the approach. You just read it. Like we can follow the follow the this flowchart. We look for the pathological jaundice. If pathological jaundice is present, then just determine the cause, like indirect cause, DCT. DCT if negative, then look for the hematocrit. DCT positive, then go for the different hemolytic problems. And if hematocrit is high, polycythemia, and hematocrit is normal or low, then go for the RBC count and RBC morphology and reticulocyte counts. And if direct cause like common cause obstructive biliary atresia, these are the uh, different cause and different management for the same causes. So now in management part, we just earlier discussed, we should alert for the neurotoxicity risk factor. So for in now, second most important thing is phototherapy. First is chart analysis, second is phototherapy. So in theory part, just I shared this content. Theory part is important is phototherapy uh, just help in this neonatal jaundice by their specific wavelength, about 400 to 520 nanometer range, to convert the unconjugated to conjugated bilirubin level. Light is effective in the treatment of hyperbilirubinemia mainly because of blue content, and sunlight is relatively ineffective despite of its ability to bleach the skin because of its low blue content. Understand? Blue content of light can help in the conversion of unconjugated to conjugated bilirubin level, but low blue content not helping this in this. So total bilirubin typically begin to decline within few hours of treatment initiation. The rate of decline is increased by increased radiation, more exposed surface area, and higher initial T total serum bilirubin level. So these three important points means अगर हम फोटोथेरेपी का इरेडिएशन बढ़ा दे रहे हैं तो जल्दी से बिलिरुबिन लेवल कम होता है। अगर हम बॉडी सरफेस एरिया ज़्यादा एक्सपोज कर रहे हैं तो जल्दी से कम होता है। दूसरा, अगर कोई बच्चा बहुत ज़्यादा बिलिरुबिन लेवल लेके आया है और आपने उसको फोटोथेरेपी लगाया तो इनिशियली बिलिरुबिन लेवल बहुत जल्दी कम होता है। दिस इज इंडिकेशन ऑफ phototherapy. And just for a thumb rule, we can understand third point. For very low birth weight baby, as a rough guide, it is indicate at level equal to 1% of the baby weight. Means कोई बच्चा अगर 1 kg का है और उसका बिलिरुबिन लेवल 10 से आ रहा है, 1% से ज़्यादा आ रहा है, तो आप बिना किसी एनालिसिस के, किसी चीज़ के, सीधे आप ये समझ लो कि इस बच्चे को फोटोथेरेपी तो देनी ही है। तुम्हारे पास कोई चार्ट नहीं है, तुम्हारे पास कुछ नहीं है, तुमने देखा बच्चा 1 kg का और बिलिरुबिन उसका 1% से ज़्यादा आ रहा है, 10 से ज़्यादा आ रहा है, तुरंत आप उसको फोटोथेरेपी स्टार्ट कर दो। ठीक है। नाउ दीज आर द रिलेटिव कंट्राइंडिकेशन, these are the mechanism, structural isomerization, the main mechanism of phototherapy conversion, and this is irreversible, and bilirubin changes into limebrin. And lumen is readily extracted by bile, phase, and to lesser extent in urine without the need of conjugation. These are the some other mechanism: photoisomerization and photooxidation. Characteristic of phototherapy devices. So this is important. Like light emission in the blue-green spectrum is 460 to 490 nanometer. Now narrow spectrum and include the region 460 nanometer bilirubin most strongly absorb the light. So in wide range, if we go more specific, then 460 to 490, and इसमें भी more specific आते हैं ना 460, ठीक है। And irradiation or at least 30 microwatt per centimeter square per nanometer. This is second very important point. Irradiation should be about 30, and illumination of the maximum body surface area, and so to decrease total level during the first 4 to 6 hours of exposure. And the infant is exposed under phototherapy source distance 35 centimeter from the skin. This is the flux meter. Now most of the NBS SNCU government providing uh, flux meter for checking the irradiation level, flux, when you providing the phototherapy. If your machine not working, if you are not machine not working and you are just put the baby in phototherapy, then there is no role, no improvement. This baby uh, become more sick with the time. So need to check flux generated by phototherapy unit at different time. It is very important. Light, and now we just go for the different light source like blue light emitting diode and compact fluorescent tubing, halogen white lights, fiber optic blanket pads. I'm not going to detail with these, just for theory point. This is important thing. Uh, this is not available in government sector periphery in blanket, fiber optic blanket and pads, but this is important that this near to skin, because they are not going to heat this baby too much, no. So in this case, distance 35 centimeter not a matter. This is the blee blanket, this is also blee blanket, this is also phototherapy. Phototherapy can be given in mother lab with the help of blee blanket, so baby is more comfortable and phototherapy is going on. Now very common condition, is sunlight is a good management option. So just look, This is just sunlight showing UVA reflected, UVB reflected, so, and the part is going inside, increase the baby temperature. So desired wavelength not going inside, but undesired wavelength going inside, creating the higher temperature, maybe hyperthermia. So sunlight is effective probably because low blue content. So probably not sure. Recommendation of sunlight for treat the phototherapy neonatal jaundice? No. Need to balance customize with evidence. So जरूरत इस चीज की है हमें कि बच्चे को बहुत ज्यादा बिलिरुबिन लेवल बढ़ा हुआ है, तो बेटर है उसे फोटोथेरेपी दो, ना कि हम सनलाइट के ट्रीटमेंट का वेट करें। हमें एविडेंस को कस्टमाइज करना है कि कितना बिलिरुबिन लेवल है और हमें क्या इंटरवेंशन करना है। This is the different phases of day. In morning we can use, in evening we can use, not in peak time of day, because this time of more chances of hyperthermia. Time of the highest irradiation of sunlight, this is also showing irradiation and 24-hour block. So just look, this is the time frame showing morning time and evening time. We can use this time to decrease the risk of hyperthermia. So something is important. Persons asking for the intermittent phototherapy versus continuous phototherapy for neonatal jaundice. So little or no difference between intermittent and continuous phototherapy with respect to rate of decline of bilirubin. This is Cochrane database. Now, most another important thing related with the phototherapy is this. These are the different type of phototherapy sources available in our workplace, like fluorescent light, compact fluorescent light, and light emitting diode LED. तो important thing क्या है? फर्स्ट फ्लोरेसेंट लाइट में मटेरियल क्या है? 6 to 8 वाइट एंड ब्लू लाइट्स हैं। उसकी जो लाइफ है वो है 1000 आवर्स और 6 मंथ। तो ध्यान रखना है कि अगर ये आप लाइट यूज कर रहे हो तो 6 मंथ के बाद बदल दो, या अगर वो 1000 घंटे चल चुकी हैं तो बदल दो। अगर आप नहीं बदलोगे, ठीक है, तो वो इतना फ्लक्स जनरेट नहीं करेंगी। ये जो व्हाइट एंड ब्लू लाइट है वो 6 से 18 का आपका फ्लक्स जनरेट करती हैं। अगर 6 महीने हो गए हैं फिर भी आप यूज कर रहे हो, नहीं करेंगी, हटा दो। 1000 घंटे हो गए हैं, नहीं करेंगी फ्लक्स जनरेट, हटा दो। ऐसे ही नेक्स्ट है कॉम्पैक्ट CFL फ्लोरेसेंट लाइट। इसमें क्या है? 4 to 6 वाइट लाइट कॉम्पैक्ट, वाइट ब्लू लाइट कॉम्पैक्ट लाइट। इसका क्या है? ये और एडवांस वर्जन है। इसमें क्या है? इसकी ड्यूरेशन जो है ना वो 2000 से 3000 आवर्स है। ये जो है ना वो ज्यादा फ्लक्स जनरेट करती हैं, 12 to 18 माइक्रोवाट करती हैं। ठीक। नेक्स्ट क्या है? एलईडी। इसमें क्या है? मल्टीपल गैलियम हाई इंटेंसिटी लाइट है। इसका फायदा क्या है? इसका जो लाइफ है वो 20,000 से 30,000 आवर्स है, एंड इसका जो फ्लक्स है 20 to 40 माइक्रोवाट है। तो क्या फायदा हुआ देखो, इन तीनों डिवाइसेस में एडवांस कौन सा है? एलईडी। क्या फायदा है? पहले तो इनकी ड्यूरेशन ज्यादा है, लंबे समय तक यूज कर सकते हैं। दूसरा, इसका जो फ्लक्स रेंज है वो अच्छा है, जो हमारा डिजायर्ड है कि अबाउट 30 तक पहुंचना चाहिए, 15 से 30 तक पहुंचना चाहिए। तो इसके यूज से ज्यादा चांसेस हैं कि वो डिजायर्ड रेंज तक फ्लक्स हमें मिल जाए। These are the example of phototherapy. Just I put it here because this is showing the LCD hour meter, means हमें इस जगह पे टाइमर को ऑन करना है और टाइम देखना है कि टोटल ये डिवाइस कितने घंटे तक चल चुकी है। इफ दिस डिवाइस above their life, then just please reinstall or replace by new device. And this this is our meter, and second picture showing this is fan, phototherapy fan. Very important, phototherapy fan should be clean. So this fan, if working, then phototherapy unit not going to heat up. If phototherapy unit not going to heat up, then their irradiation part, working part, flux generation part is good. If not working, then flux generation is not so good. Means फैन अगर वर्क नहीं कर रहा है तो फोटोथेरेपी यूनिट गर्म हो जाएगी, फोटोथेरेपी यूनिट गर्म हो जाएगी तो फ्लक्स जनरेट नहीं करेगी, और आप ये सोचेंगे कि फोटोथेरेपी यूनिट चल रही है, नहीं नहीं, वो काम नहीं करेगी. So key point in day-to-day life, this fan never be closed, damaged or covered as on heating flux will decrease. ना फैन कभी बंद होना चाहिए और फैन कभी डैमेज नहीं होना चाहिए. कभी भी फैन को किसी चीज से कवर भी नहीं करना है, नहीं तो ये फ्लक्स का जनरेशन डिक्रीज कर देगा. दूसरा, फ्लक्स मोर देन 40 नेवर हेल्प मच बट इट विल इंक्रीज डीएनए डैमेज. तो यहाँ क्या कहना है कि कभी भी आप ट्रिपल सरफेस डबल सरफेस फोटोथेरेपी लगा रहे हैं तो आप फ्लक्स को चेक करेंगे, फ्लक्स 40 से ऊपर नहीं होना चाहिए, 40 से ऊपर हुआ तो डीएनए डैमेज होगा. Always check phototherapy timer on as to know about the status of the phototherapy lifespan after its phototherapy unit is effective in term of flux generation. आपने phototherapy यूनिट लगा दी, आपको फ्लक्स चेक करना ही है कितना चाह रहा है फ्लक्स. फोटोथेरेपी एडमिनिस्ट्रेशन, दिस आर द थ्योरी पॉइंट्स. हमें कैसे फोटोथेरेपी को लगाना है, आप ये सब करते हैं. बेसिकली इंपॉर्टेंट चीज है, ओपेक मास्क शुड बी सील्ड द आई. During phototherapy, infant position should be changed off and on, maximum area of skin exposed to the light. Intensive phototherapy decline the TSB 1 to 2 milligram per DL within 4 to 6 hours. And when phototherapy is stopped, there is likely to be rebound in TSB level by 1 to 2 milligram per DL during next 6 to 12 hours. Means phototherapy बंद करने के बाद में आप बच्चे को तुरंत डिस्चार्ज नहीं करेंगे, नेक्स्ट डे या 12 घंटे बाद उसका दोबारा रिपीट कराएंगे या उसको क्लिनिकली एग्जामिन करेंगे कहीं रिबाउंड तो नहीं हुआ है. दिस इज वेरी इंपॉर्टेंट पॉइंट. हाउ टू इंश्योर इफेक्टिव इंटेंसिव फोटोथेरेपी. नाउ टर्म इज इंटेंसिव फोटोथेरेपी. सो प्लीज understand intensive phototherapy when bilirubin level is higher side and there is no arrangement of uh, actions right now. If in action transfusion, then you can go for the intensive phototherapy. And intensive phototherapy में हमें क्या ध्यान रखना है, these are the highlighted point like radiation of the 30 microgram or higher and reduce the distance of patient unit below the and baby at 10 to 15 using CFL LED lamp. मतलब क्या है, जो तुम्हारे पास यूनिट है उसका डिस्टेंस जो 35 का रखा था वो आपने 10 से 15 कर सकते हैं. एंड provide double surface phototherapy baby between belly blanket below and phototherapy lights above. नीचे से ब्लैंकेट लगा दो, ऊपर से फोटोथेरेपी लाइट लगा दो. एंड यूनिफॉर्म एक्सपोजर एंड सिंगल और कर्टन मेड वाइट क्लॉथ और एल्युमिनियम टू रिफ्लेक्ट लाइट ऑन द बेबी. मीन्स क्या है, आप रिफ्लेक्टेंट भी यूज कर सकते हैं. रिफ्लेक्टेंट यूज करेंगे तो उससे फ्लक्स बढ़ जाएगा, और रिफ्लेक्टेंट के रूप में दो चीजें, वाइट क्लॉथ और एल्युमिनियम रिफ्लेक्टेंट फाइल यूज करना है. तो यूजिंग द हाई इंटेंसिटी गैलियम एंड नाइट्राइड एलईडी प्रोवाइडिंग नैरो स्पेक्ट्रम बैंड ऑफ द हाई इंटेंसिटी लाइट. सो फॉर इंटेंसिव phototherapy, these are the component like total surface triple surface phototherapy, hydration, reflectant or flux monitoring, and medicine like utility and probiotic. And important is monitoring for the temperature and other complication of the phototherapy. So if we choosing intensive phototherapy at higher level of the total serum bilirubin or in action transfusion range borderline range, and we are not right now prepared for the action transfusion, then we can just use this thing as a intensive phototherapy. So intensive phototherapy having triple surface phototherapy, hydration management, reflectant and flex management, and utility and probiotic management and monitoring. So, just even sorry, sorry for disturbing. So, acceleration of care means थ्रेशोल्ड ऑफ टोटल सीरम बिलिरुबिन. अगर बिलिरुबिन का लेवल तुम्हारे एक्सचेंज कट ऑफ लेवल के आसपास आ रहा है तो आप इंटेंसिव फोटोथेरेपी को यूज करना है और इंट्रावीनस हाइड्रेशन देना है. और आपको हर 2 घंटे में बिलिरुबिन लेवल को रिपीट करके चेक करना है कि आपका जो एक्सलेशन केयर है वो कैसा वर्क कर रहा है. और ये जब तक करना है जब तक कि एस्केलेशन केयर आपकी एंड नहीं हो जाती है. और इस केस में आप IVIG यूज कर सकते हैं इफ DCT पॉजिटिव. अगर DCT पॉजिटिव है तो आप IVIG यूज कर सकते हैं. दिस इज द अप्रोच फॉर एस्केलेशन केयर एंड मॉनिटरिंग. मॉनिटरिंग हमें करनी है डिफरेंट frequency for the different level of severity of the total serum bilirubin level. These are the some adverse effect of the phototherapy like transient lactose intolerance, hyperthermia, irritability, electrolyte imbalance, rashes, overheating, dehydration, retinal damage, hypocalcemia, increased cerebral blood flow velocity in all preterm, even term which returns to normal after discontinued phototherapy, affect the short-term behavior of the infant due to maternal separation. These are the some complications or some adverse effect. And bronze baby syndrome also. And this is picture of bronze baby syndrome. And now some tips about the phototherapy. Protect the eye with eye patches and keep the baby neck with small nappy to protect the genitalia. After switching on the unit, check if the tubes bulb are on. Place the baby as close to light as manufacturer instructions allow. Use white cloth or aluminum foil for reflect the light to increase the flux. Do not place anything in the unit. Encourage breastfeeding. Change the position supine to prone after feed to expose maximum surface area for the phototherapy. Keep diaper area clean and dry. Monitor temperature after every 4 hours and feed after 24 hours. Measure plasma serum bilirubin level every 24 hours and change tube every 6 months or use this time 12, 1200 hours whichever is earlier and depend upon the type of phototherapy unit source. Caution to keep in mind: do not use without trying to find out the cause of jaundice. Blue light may interfere with the monitoring of the cyanosis and it cause headache, nausea, giddiness, which may affect the staff. And in direct hypertonia, it may result in the bronze baby syndrome. So next options also in recent advance like home phototherapy for newborn infant who have already been discharged and then developed a TSP above the phototherapy threshold, and treatment with a home LED based phototherapy device rather than readmission to hospital in is a option for infant who meet the following criteria like gestational is more than 30 weeks, 38 weeks, clinically well and adequate feeding, no non-hyperbilirubinemia neurotoxicity risk factor, no previous phototherapy, TSP concentration no more than 1 milligram per DL above the phototherapy treatment threshold, and LED-based phototherapy device available in the home without delay. TSB can be measured daily. Means if any baby following these red mark criteria, then baby can go for the home-based LED phototherapy. So some question and answers like, can one use white tube light in providing phototherapy? Yes. Cool daylight lamps are commonly used in India. They are effective in treatment of the non-hemolytic jaundice in term and preterm units. Occasionally, they are not effective in case of severe or rapidly increasing jaundice. Does blue light provide any additional benefit to the lowering the bilirubin level? Yes. Bilirubin is yellow pigment. Its molecules are only capable of absorbing violet, blue, or some green light. When broad spectrum light is used, only a fraction of the light affect bilirubin. So blue light is better absorbed, but green have higher penetration. The most effective light are those with high energy output near the maximum absorption peak of the bilirubin. What should the phototherapy stop? This is very important. phototherapy कब हमें बंद करनी है? Phototherapy may be stopped when serum bilirubin level falls below 14 or 15 gram per dl, or if it is below the phototherapy line. After stoppage, baby should be observed for 24 hours for rebound. Now, these are the pharmacotherapy like IVIG we can use in the hemolytic disease like RHABO incompatibility. These are the different dose in time frame protocol, and we should ensure proper hydration of the baby to decrease the need of external transfusion. Some other blocking drug for the enterohepatic circulation like agar, polystramine, uric acid, anti-mesoporphyrin, albumin infusion also help in the uh, baby if going to the external transfusion prior administration. Probiotic and Udilip also. Now, third important part as we discuss physiology, phototherapy, now bilirubin toxicity. This is the most dangerous complication of neonatal jaundice. If brain injury by bilirubin happen, then it is irreversible. So also we need to know about the bilirubin injury by brain injury by bilirubin. Actually, if bilirubin level is higher or our blood-brain barrier is intact, then low chances of brain damage. If bilirubin level is higher and blood-brain barrier is weak, then chances of brain injury more. And in case of blood-brain barrier is too much damage and bilirubin level is higher but not too much, then also chances of brain injury damage, because blood-brain barrier if intact, then bilirubin transfer from blood to brain chances of less. If blood-brain barrier is damaged, then chances of relatively less to transfer of bilirubin from blood to brain. So important thing is this, bilirubin level status should be important. Along with this, blood-brain barrier status also very important. Now, we should consider the factor that will damage blood-brain barrier. blood-brain barrier को कौन-कौन से factors affect कर रहे हैं, हमें उन पे भी ध्यान देना है, जिससे कि blood-brain barrier अगर intact नहीं है, तो हम लो बिलिरुबिन लेवल के थ्रेशोल्ड पे ही इंटरवेंशन अप्रोप्रिएट स्टार्ट कर दें. ठीक है, तो बिलिरुबिन डिपॉजिट इन द ब्रेन can result in the bilirubin induced neurological deficit. Wine, severe hyperbilirubinemia more than 25 is associated with the bind in term of preterm or preterm infant. The brain region affected by the bilirubin toxicity include basal ganglia, hippocampus, brainstem nuclei for oromotor and auditory function. So determinant of neurological injury like concentration of unconjugated free bilirubin, concentration of serum albumin, bilirubin binding by albumin, pH or H ion, or blood-brain barrier or neuronal susceptibility. So these are the factors which can affect the brain injury by bilirubin. So neurological manifestation of the bilirubin toxicity like kernicterus, chronic bilirubin encephalopathy, in which chorioathetoid hypertonic or hypotonic cerebral palsy, sensory hearing loss, limitation of upper gauge, dental anomalies, and increased signal intensity of golar paralysis on MRI. So in kernicterus, these are the as we discussed characteristic. So to prevent this dangerous complication, we just early identify the cutoff level for the intervention of action transfusion. So we just go for the action transfusion for as a most effective and reliable method to reduce bilirubin level. If we timely identify and timely interfere, we can prevent the brain damage and connectors. So early identification of ID for the ET in infant with RH negative. If cord blood less than 10 dl or hematocrit less than 30, means chances of kernicterus high, need of action transfusion. If cord bilirubin more than 5 or unconjugated serum bilirubin level 10 mg per dl within 24 hours or 15 mg dl per within 48 hours. So these are the criteria for early action transfusion. And key point is immediate after double volume action transfusion. Total serum bilirubin are typically half the value prior of the procedure, and in 30 to 60 minutes, the total serum bilirubin value return to the 2/3 of the pre-action level, since the extravascular bilirubin rapidly equilibrate the reduced vascular level. These are the theory parts. We just read, and this is the procedure of action transfusion. I just telling you just only for the awareness about the preparation of action transfusion procedure. Action transfusion is an emergency, and you are as a nursing officer totally aware for this procedure and this infrastructure and your contribution to the NICU team for the doctor. You should prepare automatically for this procedure by helping out the all necessary things like umbilical venous catheter, allocate for the blood, and donor blood arrangement, and cross match from the mother blood, and preparation of the all central line, and preparation for the all circuit. Like this is the circuit. You should know to how to prepare. Not you will not wait for the doctor and all. At least you just prepare the whole circuit, like UVC catheter for the entry, uh, y- uh, uh, USC catheter for the exit of the blood, and tie-way, and different syringes and different monitoring system. You should arrange all the things. Just today these discussion of slides just to ensure you aware you to ensure these preparation automatically uh, for this emergency procedure for help of the your NICU team, your doctors. ये नहीं होना चाहिए कि एक्शन ट्रांसफ्यूजन करना है, आप बैठ के वेट कर रहे हो कि डॉक्टर आएंगे लिख के देंगे कि आप ये चीजें अरेंज करो तब आप करोगे. I think this should not be happen if you want to prevent maximum brain injury in this baby. So this is another circuit for the Extend transfusion in which we are just using only one catheter UVC, and this is the circuit using two triphase. So complication of action transfusion like metabolic acidosis, electrolyte abnormalities, hypoglycemia, hypocalcemia, thrombocytopenia, volume overload, arrhythmia, NEC, infection. मैंने क्यों ये स्लाइड बताई आपको? ये थ्योरी पढ़ाने का कोई मतलब नहीं है, बट मैं ये आपको बता रहा हूँ इसलिए क्योंकि आपको पता है कि अगर हाइपोग्लाइसीमिया हो सकता है तो हमारे पास में डेक्सट्रोज प्रिपेयर होना चाहिए, कैल्शियम प्रिपेयर होना चाहिए। हमारे पास में अगर एरिथमिया हो रहा है तो उसके लिए हमें एरिथमिया के मैनेजमेंट का चीज़ें होना चाहिए। इन्फेक्शन के चांसेस हैं तो हमें एसेप्टिक प्रिकॉशंस लेने हैं पूरे। एंटीबायोटिक को हमें रिपीट करना है प्रोसीजर के बाद में। दिस इज दिस इज ऑल्सो वेरी इंपॉर्टेंट चार्ट। ऑल टाइम कंफ्यूजन होता है कि डॉक्टर साहब जब हमें बताएंगे तब हम रिक्वेस्ट भेजेंगे। ठीक है, डॉक्टर साहब से आप पूछिए जरूर, बट ये चार्ट आपके पास होना चाहिए कि बच्चे का ब्लड ग्रुप ये है, मम्मी का ब्लड ग्रुप ये है, तो हमारा ये चॉइस है होल ब्लड एक्सचेंज ट्रांसफ्यूजन के लिए। दीज आर द डिफरेंट अदर चॉइसेस, योर ब्लड शुड बी लाइक दैट। ठीक है, एंड सम की इंपॉर्टेंट पॉइंट, jaundice is ubiquitous, mostly physiological and transitional, may be harmful in some babies and at higher level. Screening should be start from antenatal period or for potential risk factor, and serum bilirubin in conjugation with clinical status determines choice of the treatment. Customized and intensive phototherapy is holistic approach to decrease ET, एक्शन ट्रांसमिशन। मीन्स हमारा आज का पर्पस यही है कि जितनी भी नॉलेज है, जो भी स्किल्स हैं, वो पेरिफेरी तक पहुंचे, और पेरिफेरी में पहुंच के हम चीज़ों को कस्टमाइज करें, अर्ली आइडेंटिफाई करें, अगर ज़रूरत है तो इंटेंसिव फोटोथेरेपी दें, और होलिस्टिक अप्रोच के थ्रू, इस होलिस्टिक अप्रोच के थ्रू एक इमरजेंसी और मोस्ट डेंजरस प्रोसीजर एक्सटर्नल ट्रांसफ्यूजन को अवॉइड करें। एक्सटर्नल ट्रांसफ्यूजन करना ये कोई बहुत स्किल और टैलेंट वाली बात नहीं है। ये बहुत रिस्की प्रोसीजर है जिसमें कि बहुत लाइफ थ्रेटनिंग कंडीशन हो सकती है इसकी कॉम्प्लिकेशन। तो बेटर ये है कि अर्ली डायग्नोज करना है, अर्ली इंटरवीन करना है, चीज़ों को कस्टमाइज करके इंटेंसिव फोटोथेरेपी देनी है और एक्सटेंस ट्रांसफ्यूजन को बचाना है। Avoiding long-term neurological damage is the goal. Breastfeeding is the panacea to prevention. Absolute red flag like staining of the palms and soles and white stool. Bilirubin neurotoxicity is the important cause of CP, developmental delay, and hearing impairment in the low middle income countries. Reversible in early phase of acute bilirubin encephalopathy, and early detection and rehabilitation of hearing loss is important for the development of speech and language skill in hearing impairment children। मतलब कहने का क्या है कि भाई अगर हमारा कर्निक्टस हो गया तो एक्यूट फेज में ही रिवर्सिबल होता है, क्रॉनिक फेज में रिवर्सिबल नहीं होता है, और हमारे ये डैमेजेस आते हैं, फिर हमें उनको रिहेबिलिटेशन करना पड़ता है। A scheduled follow-up protocol for physical and neurodevelopment assessment during early childhood would potential to helpful for the early detection and intervention for neurodevelopmental delay। Means कोई बच्चा आपके पास वाइंड में आया, कर्निक्टस के अर्ली स्टेज में आया, आपने एक्सटेंड ट्रांसफ्यूजन कर दिया, बच्चा बच गया, अब आप जरूरत है कि आप उसका फॉलो अप प्रोटोकॉल बनाएं और उसमें फिजिकल एंड न्यूरो डेवलपमेंटल असेसमेंट उसका करें, जो कि बहुत ज़्यादा हेल्पफुल है कि बच्चे में पहले से ही हम अगर कोई डेवलपमेंट डिले आ रहा है, कोई डेफिशिएंसी आ रही है, कोई डेफिसिट आ रहा है, तो इसको टाइमली इंटरवेंट करें और बच्चे को हेल्प करें उसके रिहेबिलिटेशन में। सो नाउ की पॉइंट इज अर्ली आइडेंटिफिकेशन एंड अर्ली इंटरवेंशन टू डिक्रीज द ओवर क्राउडिंग एट हायर सेंटर एंड टू डिक्रीज द मॉर्बिडिटी। अगर हम इस लेक्चर के बाद में उन चार्ट को यूज करके हम एनबीएसयू पे ही बच्चे को फोटोथेरेपी लगा दे रहे हैं और उसको एनआईसीयू और एसएनसीयू शिफ्ट नहीं कर रहे हैं, तो आज हमारा लेक्चर का पर्पस पूरा हो जाएगा। और अगर हमने दूसरा पॉइंट, अगर हमने एनआईसीयू और एसएनसीयू पे ही ये डायग्नोस कर लिया कि इसको बहुत ज़्यादा चांसेस हैं कर्निटस हो सकता है, और उसको हायर सेंटर पर टाइमली रिफर कर दिया, तो बच्चे में कर्निटस होने से बच गया, मॉर्बिडिटी होने से बच गई। तो आज के लेक्चर का पर्पस पूरा हो जाएगा. सो वी जस्ट फॉलो दिस प्रोटोकॉल, दिस cycle properly. Clinical history, examination, TCB, total serum bilirubin level, as important discussed chart, and customized phototherapy, intensive phototherapy, and follow-up. And this is acknowledgement to my respected teacher, Dr. Chinmay Chetan sir, Dr. Sakit Patra sir, and Professor Krish Gupta sir, Professor Asud Rai sir, and Professor Syed Manazir Ali sir, who is my teacher at different phase of my career, and he always mentor me for working hard. And these are the references. And thank you so much for hearing me. And if any issue, any confusion, any query, please mail me, please WhatsApp me. I just share my email and WhatsApp number to you on Telegram group, and you can also share your query on Telegram group. I will try my best to timely reply you. Thank you so much. Good day.